Bergson, and I'm going to talk to you a little bit now about thyroid cancer and specifically the decision about removing part of the gland or all of the gland in the setting of thyroid cancer diagnosis. And this is a topic that can be a little bit confusing. And part of the reason that it's confusing is because there's more than one reasonable or appropriate way to proceed. There's not necessarily a strict right or wrong, and that can be the cause of some confusion. But so the first thing, of course, is let's look at the thyroid gland. This is the thyroid gland here, and you can see that it divides itself nicely into two sides. We call them lobes, connected by a little bridge of tissue called the isthmus. And so when people have a nodule in their thyroid or a cancer in their thyroid, the first question that's often asked is, well, why do you have to remove even one whole side of the thyroid? Why can't you just remove the nodule? And that's a reasonable question, and then the answer really comes down to the technical aspects of doing thyroid surgery. Basically, it just doesn't work. You can't really carve the nodule out from the surrounding tissue. It just doesn't work well. It makes kind of a mess. It'll tend to bleed, and it can be difficult to know whether the nodule begins or ends here or there. If there's multiple nodules, it can be difficult to know which was the nodule that's suspicious versus which one wasn't. So it just doesn't work well to do that. In addition, if you ever had to go back and operate on that same side again, there would be scar tissue and things like that, and that would make surgery in the area that much more difficult and potentially dangerous. So there's only two operations that get done on the thyroid gland. We do either one side or both sides. And so when it's one side, we call it hemithyroidectomy, and when it's both sides, we call it total thyroidectomy. And so if someone has a tumor, a cancer in one side, and we've just talked about why you can't just take that out. So okay, you take out the side. Why would you need to take out both sides? How does that help? Well, there are reasons why that can help, and I'll try to go through them. First, oftentimes, very frequently in thyroid cancers, they can be what we call multifocal, which means that there's tiny little areas of spread of the cancer within the gland. They might be visible on an ultrasound, or they might be so teeny that they're not visible. They might exist on a microscopic level, but it's very common for there to be other little microscopic nests of cancer cells scattered throughout the thyroid gland. And so the concern would be that if you don't take out the whole thyroid gland, then you're going to be potentially leaving little nests of cancer cells that could then cause problems down the road. So that would be one reason. The second reason is that it can facilitate the use of what's called radioactive iodine. Radioactive iodine is an additional treatment that can be used for thyroid cancer. Iodine is one of the building blocks that the thyroid uses to produce thyroid hormone, and it takes the iodine up from the bloodstream to use it to produce the thyroid hormone, and virtually no other tissue in the body takes up iodine, so that what's done is that iodine is made radioactive, and it's given in pill form, and therefore when you ingest it, it'll get taken up by any leftover thyroid cells that could exist anywhere. Any benign little cells that might exist, because there's always going to be just a little bit of thyroid tissue left behind, even on a microscopic level, maybe still attached to the trachea because it's very stuck. Or there could conceivably be cancer cells somewhere. Maybe there's a microscopic cancer cell hidden in a lymph node somewhere that was undetectable on your preoperative imaging. The idea would be that radioactive iodine can potentially zap or destroy any microscopic thyroid cells that are left behind, either benign little rests of tissue that would never harm somebody, or cancer cells that could potentially exist. So that's a benefit, because you cannot use radioactive iodine effectively if there's a large quantity of thyroid tissue still left in the neck, as there would be in the case of leaving the other side. So the ability to use radioactive iodine, which is helpful in some patients, is also facilitated by removing both sides of the gland. Once you've used radioactive iodine, you can better monitor using blood tests, because there's a protein called thyroglobulin that's produced by thyroid tissue that should essentially be zero after every thyroid cell has been eradicated, and then you can monitor that using blood tests. If you have not gotten rid of all of the thyroid cells, you're less able to use these blood tests to monitor a patient after treatment for thyroid cancer. So that's another potential benefit of doing a total thyroidectomy instead of a partial thyroidectomy. Now, what are some of the downsides to doing a total thyroidectomy versus a partial thyroidectomy? Well, the downside is that you're definitely going to have to take thyroid replacement medicine if you have your whole thyroid removed. If you have just part of your thyroid removed, you have about a 75% chance of not having to take thyroid medicine. There are some exceptions to that, because sometimes after treatment for thyroid cancer, they like to give you thyroid medicine even though you don't technically need it, because it's thought it can help in not promoting additional growth. But for the most part, the idea is that there's a very good chance that you won't need thyroid replacement, and you will have enough of your own naturally produced thyroid hormone after just removing half. So that's a potential benefit. The other potential benefit is that you have less surgery. There's less risk of surgery if you have less surgery. There's, of course, a nerve that's not shown well in this picture, but there's a nerve called the recurrent laryngeal nerve, one on either side, that goes to move the vocal cords. And when you operate on one side, you're exposing that nerve theoretically to risk. The level of risk is extremely low. The chances of nerve injury are less than 1%. But if you don't operate on one side, then the risk to that nerve is zero. So you do take on some additional risk in terms of exposure of the nerve. And then the second issue is the risk of trouble with parathyroid function. You'll recall from one of the other videos that there are 4 little glands on the back side of the thyroid gland called the parathyroid glands. Those need to be left behind and left in place during thyroid surgery. And if all 4 of them are damaged, which is only possible if you're operating on both sides, there's a chance a person could have trouble with low parathyroid function, resulting in low calcium level and the need for long-term calcium supplementation. If you're just having half of your gland removed, 2 of those parathyroids are being left totally undisturbed. Therefore, there's no chance of injury. Therefore, there's virtually no chance of this problem with low parathyroid and low calcium. So those are some of the pros and cons, but you might be thinking to yourself, yeah, but I just want to make sure I'm treated properly for my cancer. Isn't that what's most important? These other things are interesting, but I want my cancer treated. And that's, of course, the crux of the matter. So that gets into a topic that has really evolved quite a bit over the last 10 or 15 years. 15 or so years ago, just about everybody who had a thyroid cancer had a total thyroidectomy, and often, very often, had postoperative radioiodine treatment. That was the maximum treatment, and that was routinely given. There was one group of doctors and researchers, primarily at Memorial Sloan Kettering Cancer Center in New York City, who always argued that that wasn't necessary to do all of that. You could get away with just treating these patients with hemithyroidectomy in a lot of cases. And it was a big debate for a long time, and initially most of the thought was total thyroidectomy and radioiodine, and it was just this one crew who argued otherwise. But eventually, the data proved that the doctors from Sloan Kettering were correct, and that many patients with thyroid cancers can be treated with just partial thyroidectomy. And there's two important points to understand about it. One is that every case is different, and basically these situations are stratified into risk categories, and there's different aspects that go into categorizing the patient and their risk factors. There's the age of the patient, the size of the tumor, the type of the tumor. There's a lot of different variations in thyroid cancer. Some are known to be more aggressive, some less aggressive. There's the issue of whether or not it's broken through the capsule of the gland. There's issues regarding whether or not there are lymph nodes involved. All of these things get put on the scales, and an assessment of the risk category of the patient is made. So it's not one size fits all. But over time, it's clearly been shown that many patients can be treated effectively with just partial thyroidectomy, even though they have a thyroid cancer. Now, you might also be thinking to yourself, but wait a second, earlier on you told me that this might be scattered throughout the gland, and there might be little teeny nests of cancer in other places, and you told me that radioiodine would zap little microscopic cancer cells that might exist somewhere in a lymph node. Well, what about those? If I just do a hemithyroidectomy, aren't those going to cause a problem? And the simple answer to a complicated issue is that if you look at people who are treated with total thyroidectomy, and then you look at people who are treated with partial thyroidectomy, who are matched in terms of their risk stratification, the people who have partial thyroidectomy will have more instances of recurrence of their cancer as you follow them out for many, many years. However, so long as that person is followed and those recurrences are managed with additional surgery, those patients, even the ones who recurred, and most of them are not going to recur, but there will be more recurrences than in the other group that was treated more aggressively. But even including those patients who have recurred, so long as they are treated appropriately with additional surgery when it's necessary, the long-term outcome, survival, prognosis is exactly the same. In the other group, who was treated at the outset with total thyroidectomy and radioiodine, that group of patients will have less recurrences. But their overall survival will be no better than the group that was treated less aggressively. But they will have less recurrences. There will be less instances of second operations. There also will be probably some greater incidences of complications from additional surgery. You do more surgery, you're going to have more complications. So some of those patients will be spared a second operation because they didn't have a recurrence. But some of them may experience a complication from surgery, such as a nerve injury or a parathyroid issue that they would not have had they had less surgery. So there's a pro and a con that exists in either group, and it all just needs to be weighed and assessed. And part of it has to do with what a patient themselves is most comfortable with. Ultimately, you have even though it's a cancer that people do universally, almost universally, very, very well with. The outcomes are excellent across the board, and because of that, there's more than one way to proceed, and both ways can be right. Both ways can be okay. Both ways can be reasonable. It comes down sometimes to comfort and preference, within a range of what's deemed appropriate based on that risks stratification or risk categorization. So I hope that was helpful, and thank you for listening.